Hello, everyone, and welcome to today's Physician Echo Clinic for the Engine and NJAFP Project Echo. Before we begin today, I would like to go over some housekeeping. We appreciate and value your participation in today's webinar. For educational and quality improvement purposes, this tele-echo session will be recorded. By participating in this session, you are consenting to be recorded. Please protect all patient privacy, and please do not provide any PHI information. If you have any questions at the end of this presentation, please email me at jsatmary@njaap.org. Please mute your microphone when you are not speaking. If you are on a computer, the microphone is located at the lower left of your screen or at the upper left of your screen through the Zoom application. If you are on the telephone, please press *6 to mute and unmute yourself. Please communicate clearly during the session. Please speak clearly when talking during the session, and please use the chat function to send any messages that you would like to send privately, or you would like to be saved in the chat messaging. Do not put your phone on hold, as if you must leave the meeting. If you put us on hold, we will hear the hold music throughout the webinar. So now I'd like to take a roll call of all of the practices that are participating in the project. Capital Health Internal Medicine Residency, who is on from your clinic? Okay. Freehold Family Health Center, is anybody on from that center? Okay. Happy Healthy You Family Medicine? Okay. Palisades Hospital? Okay.
Did you say St. Francis?
Oh, not yet, but we will be coming up to St. Francis soon. That was Palisades Hospital. Robert Wood Johnson Medical Associates? Okay. St. Francis Medical Team, who will be joining us from there?
Denise Baker, Analytics.
Okay. Anybody else?
Hi, this is Jackie Williams from Virtua Mansfield.
Okay. And then Virtua Mansfield. Anybody else from that team? Okay. So now for the accreditation statement. Application for CME credit has been filed with the American Academy of Family Physicians. Determination of credit is pending. Each physician and clinician must complete the evaluation to receive credit after the webinar is completed today. You will receive an email by close of business today from me with the link to the evaluation. And here are the following individuals that were involved in the making of today's presentation. The following individuals have no financial conflicts of interest relevant to this activity. So now I would like to introduce two of our speakers today. One of our speakers will be Dr. Cindy Barter, who attended the University of Kansas Medical School, where she received her doctorate of medicine. She completed her residency at DeWitt Army Community Hospital in Fort Belvoir, Virginia. Since 2009, she has been on the faculty for the Hunterdon Family Medicine Residency Program. She directs patient care at Hunterdon Family Medicine at Phyllis Barber and is responsible for providing and teaching maternity care and inpatient family medicine rotations. Fran Griffin has worked in healthcare, and now I would like to introduce Fran Griffin as well. Fran Griffin has worked in healthcare for over 30 years, particularly in areas of quality improvement, patient safety, and innovation. Ms. Griffin is a registered respiratory therapist and faculty at the Institute for Healthcare Improvement, where she worked for 8 years. Previously, she worked at the CMS Innovation Center and several health systems in New Jersey. Fran works with NJAFP and other organizations on clinical QI programs and is author of numerous articles related to patient safety and quality improvement in healthcare. Now, without further ado, I would now like to turn our presentation over to Fran Griffin and Dr. Barter. Fran?
Okay, I apparently got remuted after I unmuted myself, so I don't know how that happened. So apologies if this is repetitious, but welcome back, everyone. Glad so many of you could make it today. And I'm trying to advance the slides. What we did before, Jake, is not working. So why don't you just advance this? Okay, there we go. All right, so the learning objectives for today's session, just very quickly, we're going to talk a bit about how design of work actually impacts outcomes, which will set us up very well for the QI session tomorrow. And hopefully following today's session, you'll be able to identify within your own practice a workflow related to vaccines that can be worked on using the QI methods we'll be talking about tomorrow. So our first goal is to do our CME pre-question. So Jake, if you could pull up the poll on this, and if everyone could please answer this when you see the poll. If you don't see the poll, because it is a pop-up, you can type the letter of your answer into the chat. Please do send it to everyone if that's the case. And Jake, just let us know when we've got a sufficient number of answers.
Mm-hmm. Polling has been launched, everyone. Thank you.
How many have we got, Jake?
Well, I think we got about 50% answer.
All right, well, those of us who are on the panel can't answer anyway. Okay, great. All right, so we've got some variation in our answers, which is good because it gives us something to talk about. So we can close this out and we'll review what the correct answers are at the end of the session. All right, it's not letting, there we go. All right, so at this point, I'm going to turn it over to Cindy to talk about a case study related to pertussis. Cindy? Cindy, you may be muted if you can hear me. Jake, do we know which number is Cindy?
I do not see her logged in at this call, and I don't.
Okay, so she was seeing patients right up until noon, so it's entirely possible she got a bit tied up with the patient. So why don't we go to my portion, and then if Cindy's able to join a little late, we can just come back to these slides. So I'm going to move us over. I am not qualified to take through the case study. So we do have these talking points on vaccine for adults. So I don't know if Angie or Michael, you wanted to speak to these or whether you'd prefer to wait until Cindy joins us.
I think it's probably best for Cindy to present that, but so when she comes on, if she's not prepared to do that, I'm sure either Angie or I could comfortably move through those.
Okay, great. All right, so we'll jump into the other portion of this. And Jake, if you see Cindy join, maybe you can just shoot me a message via chat. That would be helpful. So we wanted to talk a little bit about how workflow actually impacts results, including outcome results. And I've got a couple of clinical examples to share with you. They're not vaccine related specifically, because I didn't have a vaccine one, but they'll make the point fairly well. So we're going to talk a little bit about variation and variation in how work is done. So many of you are probably familiar with Deming. If you've ever taken a quality course, you probably heard Deming mentioned in a lot of the NJFP work, really one of the founding thinkers around quality improvement. And you can see the quote here that, he really talked about, everything has to do with understanding, controlling, managing, and reducing variability. What I like about his quote is he doesn't mention eliminating variability, because we can't, nor should we try to get all variation out. But, and if folks could please mute, if you could, we're picking up some background conversations, that would be super helpful. Thank you. And Jake, I don't know if you have the ability to mute lines from other people. So variation is really important. And Schuhart, who also the creator of control charts as we know them, really viewed that the role of anybody trying to manage anything, whether it's a practice or whether you're talking about manufacturing, is to understand the two types of variation and make decisions on them. So what does this have to do with clinical stuff? So I'm going to give you an example. This is real data from a project that I worked on a few years ago, which hopefully will come here. There we go. So this is antibiotic timing. So this is hospital data looking at antibiotics prophylactic antibiotics being administered 0 to 60 minutes before incision. And the ideal time is 30 minutes before incision so that there's sufficient tissue perfusion for the antibiotic to effectively help in the prevention of a surgical site infection. And so here you can see when we look at the data as far as the percentage of antibiotics administered in that window of 0 to 60 minutes before incision, you can see that for 6 straight months, it was above the goal of 90%. So looking at it this way, you might say, wow, this is great. We're above 90%. Better would be getting closer to 100%, but this is pretty darn good performance. Isn't that great? Well, if we take the data and look at it a slightly different way, and this next graph, this is the exact same data. The only thing I did was I removed from the graph those that were administered in the time frame that we were aiming for, because that was most of them, and so it just cluttered up this graph way too much. But if you look at the ones that were not within 0 to 60 minutes, so outside of that 90%, look at the degree of variation that there is. Look how many patients had antibiotics. You can see the biggest spike on here was 2 hours prior to incision, some as many as 5 hours prior to incision, and then some 5 up to 10 hours after incision, outside the range completely to be at all effective in preventing surgical site infection. So it's really important to not only understand what percentage of times do we get it right, but when we miss it, how much variation is there in what we see? Because it really can impact on the outcomes. Because none of us would want to be, nor would we want a member of our family to be the patient who represents 10 hours after incision on this graph. So a key aspect of improvement is not just improving the percentage, but also really decreasing down the amount of variation in the data. So let me give you an example from a physician at Mayo. He created this slide, which will pop up in a moment. There we go. This is from Terry Borman at Mayo. And he created this slide when about, 10 years ago, we were all working for the first time a lot on reliability, trying to get things more reliable. Less variation is more reliability. And he came up with this graphic to show kind of where we were and where we needed to be. And a physician colleague shared a great story that was published in the literature from this that I will mention as well. So on the left side, you can see it says standard of care, and there are 2 lines. Those represent the evidence base, if you will. So lots of things have evidence base within them. For example, prophylactic antibiotics given 30 minutes before incision. David Klassen and others published a lot on the right timing for that. So we have a good evidence base. But yet we saw, even when most were within those 2 lines, within the standard, we still had a lot of variation. And if we have different processes for doing it, so here you can see there could be 4 different ways of doing something. They'd all be consistent with the evidence, but they'd be different. Well, what happens when we have different ways of doing things, we get different results. And typically what happens is we're consistently, as you can see in the 3rd box down there, between 60 and 90%. It's really hard to break 90% on anything if there's variation in the way people are doing the work. It's really hard to learn when something goes wrong if there's variation. And for new staff coming in, it can be hard to orient them to the work when there are multiple ways of doing things. So advocating for moving from what's on the left to on the right, where we're still within the evidence base. We're not going outside of that because that's research. That's not what we're trying to do here. But we come up with one way of doing the work in our organization. And that's what really contributes to getting results of 90% or better. And then you can really learn when something doesn't go as expected, whether or not that was an unusual case or whether there's further tweaking needed to your process. A great example of this that I heard when I was co-presenting with Jim Reinertson a number of years ago, a physician who's done a lot of quality improvement work. He mentioned a study that was published in one of the journals from Brigham and Women's in Boston around postoperative glycemic control for CABG patients. And most of you probably know the evidence base is to keep glucose for like 72 hours after surgery under 200 in order to reduce the risk of infection following CABG. Well, at the Brigham, they had 3 physician groups. So they kind of looked like the graph on the left here. All 3 surgical groups each had their own protocol for managing glucose postoperatively. Each one had a different target glucose and different levels for when insulin should be administered. They were all within the evidence. They were all doing under 200, but they were different. Had to respond differently when glucose was measured depending on who the surgeon was. And so it would be very easy for the staff to make a mistake or get mixed up, and there's extra work of having to go look and see, oh, now which surgeon is it? They started looking at this because they were having sternal wound infections. And so they brought the 3 physician groups together and they said, you as the physicians need to decide, but we need to end up on one protocol. So please come together and compromise a little bit, because one group was really conservative and one group was really aggressive and with their glucose levels, and the other one was kind of in the middle. So they kind of had to compromise, come to one, and they said, well, we'll start a little on the high side, and then if we still see sternal wound infections, we'll come down a little bit lower and lower. And they went through this process repeatedly over the course of like 2 years. And their sternal wound infections really started to drop and then go away. The other thing that they noticed, though, because they were tracking the data, they were having a lot of hypoglycemic events on the post-op cardiac surgery floor. And those all went away when they moved to one protocol. So when staff had one way of doing things that all the physicians agreed to and that was within the evidence base, their results got better and got to levels that they hadn't even anticipated, both for sternal wound infections and hypoglycemic events. So it can be done, and there are some good examples in other clinical areas. So it seems logical that this would apply for vaccine work as well. So a couple of questions that I want to pose to the group and hope that some of you will be able to answer. Thinking about vaccine processes in your own practice. Trying to get the slide to advance here. There we go. So think about within your own practice for the work around vaccines, whether it's just, let's start with something that's the first step, perhaps checking somebody's vaccination status, either prior to the visit or on patient arrival. If you were to ask everybody in your practice setting how they do it, would there be differences? If a patient's vaccination status needs follow-up, they say that they haven't received a vaccine, they don't know if they've received a vaccine, they have concerns about it, do people handle this differently? Who discusses with the patient if the vaccine has not been received? Same way, how is it done? When is it done? How is this information documented and updated? So we'd really like to hear from all of you at this point, and so hopefully some of you will unmute and weigh in or type something into the chat. What do you think the degree of variation might be for things like this within your own practice? Would you, if you went and asked these questions, do you think you'd find differences? Is it fairly well standardized? Where are you currently?
This is Sarah. I'll go first. I think one thing is that we have a standing orders at St. Francis, but I don't think they're always used all the time when we have personnel sick or not in the office. I don't think it's used all the time. I assume that would be a variation. The other thing is some residents talk about vaccination right up front when they're seeing the patient. Others may talk about it as they get to the end of the visit and after they deal with all the other problems, then it may be almost an afterthought, although I don't want to call it that, but it may be something that's low on the list in terms of the visit, and it will depend upon how residents view this. and how quickly they bring it up during the visit.
Okay, great. Thanks for that. That's helpful. How about some others? What are your thoughts on what might be happening in your own organization or practice?
Hi, this is Mary Campanello from Virtua Mansfield. I don't know if anybody else from the practice is on, but the thing we did too was also we have standing orders for pneumonia vaccines and flu shots, so the MAs are empowered to check on that and give the vaccine. I think where there's probably variability is whether each medical assistant does the pre-visit planning, which could be done to check on, which vaccines are needed at a visit. And we do try to do that with some discussion with a huddle before the workday. But again, whether it's 100% followed is probably variable. But we have tried to do that. And then I think it's pretty much still on the clinician, though, if there's a vaccine missing and it needs to be explained to the patient, it's pretty much on the physician to do that, although the MAs might give us some heads up that, oh, this person needs a shingle shot or something to that effect.
Okay, great. Thanks so much for sharing. And I see somebody also typed into the chat, although I don't know who it is, about identifying that vaccine decline documentation is not happening correctly. And a process was identified to improve it. Would be great to know what the process was and whether or not that actually improved, and were you tracking some data to show that? Great thoughts. Anybody else with thoughts or just anything that you think you might do after this? Do you think it might be useful to talk amongst your team following the call to ask some of these questions? A really easy way to do this, because some colleagues and I have seen people do this a number of times, you don't have to ask everybody. Now, of course, it depends on the size of your practice, but if you were to just go ask 5 people, how do you do the following? If you get more than one answer, then you've got some variability that you might want to look at. Now, again, I'm not saying all variability is bad. I do want to be careful about that because that's not the case. And sometimes variation makes complete and total sense because you always want to be adjusting for patient conditions. But if you've got lots of variability and lots of different ways people do things, then you can end up with very different results. So if your vaccination results are not where you want them to be, then it's worth a thought. Great to hear the one example we just heard of some standing orders. The same physician I was talking about earlier, Jim Reinertson, told a story from his own practice one time where one of his staff members finally said to him one day, because I think there were 4 docs in the practice, that they had 4 different sets of instructions for what to do for a sore throat. And the staff person in exasperation turned to him one day and said, there's really not a whole lot of difference between what each of you have. Why can't you just all come up with one? And they paused and went, wow, you know what? We should do that because they didn't have a lot of difference. So some things to think about. So on the next slide, I just listed a couple of things to think about, and then I think Cindy's here, so we'll go back to the case study. Examples of standard.
Hi, I'm sorry. Can I just I finally was able to unmute myself and dial. You asked about our experience. If it is possible, I can explain it now. This is Delorum from Capital Health.
Sure, go ahead.
But we realized there was a lot of different ways to document the declination in EMR, and also the discussion. Discussion was happening, but people were not documenting. And some people were documenting by making notes in body of the progress note, in assessment plan. And basically there is different method, and we realized that, people are doing differently, and also EMR can capture only one method. So then after that, we came up with the best ways of documentation. We educated everybody, and we asked everybody to by email and by team huddle discussion and by during a staff meeting, so three way. To ask them that this is how the documentation should happen. so we can capture the data better. So this was our basically experience with having different workflow for different issue. Basically, I wanted to share.
Great, thank you so much for sharing. So I'm not going to spend a lot of time on this slide because I'm sure most folks know a lot of this already, but these are just examples of standardized approaches. Sounds like some of you are using some of them already, and any opportunities you have, just even standardized documentation, things that you give to patients, how equipment or supplies are managed would be really good. So at this point, I think we're going to go to the case study, since Cindy is now with us, I believe.
Okay.
Cindy, are you there?
Well, in order next.
I am.
Okay. Only the flu and the
And if others could please mute your lines because we are picking up somebody's conversation. Thank you. Hey, Cindy, it's all yours.
Okay. So we've got a 65-year-old woman. She's new to Medicare. She has not had insurance for the last 10 years, and she is expecting a new grandchild in a few weeks. We are at this time of year where it is flu, and so trying to figure out which vaccines would you recommend for her, where do you think she could get them, and what are the options? So this is where input from folks. What vaccines would you recommend to her with no insurance for the last 10 years, so really hasn't had much care, but is otherwise healthy?
Come to us so we can give you the shingles. No, she can go to the pharmacy for shingles.
Yeah. Pneumococcal.
So I've heard pneumococcal, I've heard shingles.
This is Mary from Mansfield, Virtua. I would say probably the first thing is the flu shot and also Tdap. We sometimes have experienced problems with Medicare coverage for the Tdap, though, but with the grandchild coming, that would be an important thing. Potentially, she could get it at a health department in the county if she had no other coverage.
And so,
Okay, and then
go ahead.
this is Sarah. She needs the pneumococcal vaccine, preferably the Prevnar first. But if you don't have it, I guess the 23 valent.
Mary, going back to your point about the Tdap, you said that she could get it through the local health department if she can't afford it, since Medicare doesn't cover that?
Yeah, I think that's a possibility. I haven't tested it myself in a while. Luckily, we've had patients who have been able to manage that for the most part, but then we've had a couple of cases where patients got bills and surprise later on. So we have been trying to think through that, making sure patients know their responsibilities regarding the tetanus under Medicare.
And I know we've spent some time on previous calls talking about the shingles and where people get it from your office. And so, if we've got the pneumonia, the flu, the Tdap, the shingles, would you want to recommend all 4 of those today? And I don't think there's a right or a wrong answer, but sort of thinking about workflow, what would be your process in your office for, like, do you have a standardization of which vaccines and when, and how we make sure that we don't get some of those missed?
Josette Palmer from Happy Healthy You. There's no, what you could do is split them up and just leave the order in the chart, and so that and then let the patient know that she needs to come back. With the baby coming, the Tdap that's probably the Tdap and the flu would be the 2 most important for right now. If you wanted to split them up, and then the Shingrix, she would probably be getting that from a pharmacy anyway because of reimbursement which was previously discussed. And then can always come back and do the Prevnar another time.
Any other thoughts? Anybody else? But I would agree about putting flu and the Tdap as the two top priorities with her trying to be around a new grandchild. But again, trying to look at in your office, you know, in our EMR, I can't do a future order for a vaccine. So we've really struggled with that. You know, where in our workflow do we put it that we're going to have somebody come back for a vaccine, since I can't order that in the future? I can order labs in the future, but I can't order vaccines in the future. So we now put it in a communication task to the nurses, which sometimes has gotten lost. So we're still trying to figure out how in our office to put in those future vaccine orders consistently.
At least for this Mary again, for the pneumonia vaccine, at least if we had, like we have standing orders for that, so if somebody would come back for that, the MA can go ahead and just do the pneumonia shot and document it then, which could solve some problem like you were just describing. But fortunately, we do have a future order process in our EMR that would help us for future tasks.
Right. So that was kind of what I had as far as the case for today. And I'm sorry that I was on late, so I don't know if there had been other discussions previously about looking at workflow.
So Cindy, we have this set up as a poll if you wanted to do it quickly just to get more feedback. Just go back one and open the poll.
So which vaccines would you recommend?
I think we have it as a poll.
I apologize. We do not have this set up as a poll.
Ah, okay. I thought you said that it was. Okay, never mind. So we should go to the talking point slide. So Cindy, did you want to go through this one, or would you prefer that Michael or Angie run through these talking points?
If Michael or Angie, if you guys have looked at them since I was seeing patients all this morning, that would be great.
Of course, that having seen patients is no excuse, doctor. Kidding. So Angie, I will give you first dibs on this if you choose to do that. If not, I'm happy to quickly go through these. Okay, so we were hoping today to have Megan Avalon, who's the president of the New Jersey Community and City Public Health Officers, on to discuss this issue because it is near and dear to her. And in our conversation earlier yesterday with Angie and Fran, Dr. Bartel suggested that, you know, there are barriers there that we really need to address. And so these are the talking points that Megan was going to be covering, and I'll warn you in advance that she's far more eloquent than am I. But nevertheless, we can take these through, take you through each one of these. And the big takeaway message is that for those patients who are Medicare recipients, can participate and receive these immunizations at their local public health office for any of those vaccines that are not covered on any part of their current coverage. And going beyond that, we hope to have a comprehensive list of those offices from the association available to you on Simple QI or otherwise distributed as seen appropriate by Fran and others. So as you could see, the majority of the health departments provide the Vaccine for Adults program, VFA, which is a different than the 317 program. And we'll talk a little bit about what those differences are. But essentially, the VFA program is a much simpler, seamless, and less time-consuming approach to being able to receive many of these vaccines for those patients that are not covered otherwise. Of course, the best, and once you have the list, but the advice can be for coming from the medical home is to suggest to the patients that they reach out. And again, we hope to have that list, comprehensive list of offices with the contact information, so it'll make it a little bit easier for you to be able to share these with your patients and with your staff to share with patients. Sometimes the local health department will charge a small administration fee, but that's not common. But it is important that you know that for some of them, that might be a possibility. So in terms of the 317, the differences between VFA and 317 is 317 is covered by funds that come through the CDC to the states and are distributed. Unfortunately, in New Jersey, there are not a great many of the 317 providers. Number one. Number two is they're often positioned as kind of the safety net. It's not really altogether that much of a secure safety net, in the sense that in order for a patient to receive vaccines from the 317 program, they have to be on the panel of the FQHC, which is where most of the 317 providers reside. And so they're not, and Doctor, you might have some commentary to offer on this, but I don't know of too many practices that are willing to give up patients or recommend that they join another practice in order to receive those immunizations. So that's a huge benefit to the on the VFA side of the equation. There is a requirement at the VFA, at the public health offices, that the adults have to consent to having their information entered into the New Jersey Immunization Information System, which is really a good thing. It's a terrific tool that is experiencing growth within the state of New Jersey. It's predominant in the pediatric realm, as they have to enter all vaccines provided into the system. But it's high time that we start getting more involvement from family medicine and pharmacies and the like, so we can have this comprehensive database. And in terms of those vaccinations that we often hear of being a barrier, both on the cost side, is shingles and pneumonia vaccines, and these are available at those public health offices. And again, lastly, as was mentioned at the top of this short edition here, that Medicaid recipients can participate if their plan does not cover any part of the vaccines. So in some instances where you've got Part D and the coverage is there, that's fine and doesn't present any challenges. But for those who do not have that extended care, the public health offices are a really valuable backup to that. And we encourage you to recommend to those patients who are either non-covered or undercovered to use that as a resource. Back to you.
Great, thanks, Michael. So let's talk a little bit about the action for, and then also we have our post question. So for CMEs, stand by for that. We'll get to that in just a moment. So tomorrow we have our QI session, and some of you on today's call may be on that one as well. And we'll be talking about what do we do with looking at designing the work to reduce the variation we were talking about and improve. So what we'd ask you to do between now and tomorrow is identify a work process or a workflow related to vaccine that you suspect may have variation, or maybe you already know has variation in it, that Your team could work on applying QI methods around process mapping, which we'll talk about in depth tomorrow. I listed a few examples here, but I'm sure there are many others related to vaccines, such as how do you collect vaccination status? How do you check it with patients prior to or on arrival? How do you discuss vaccines not received? Provide referrals or prescriptions if patients are going to other places to receive them. It can be any process you want. I would encourage you to think about something small like the examples here rather than the entire vaccination process with all of its pieces as a place to start. And your teams that come to tomorrow's call should arrive on the call ready to share what process you're going to look at working on, because we'll then go through process mapping and some details about how to apply this in hopes that delving into this will help you in improving both your vaccination rates and the documentation of them as well. So that's the plan for tomorrow, and we'll bring up our post question now for CME, and then we'll have a few minutes for any remaining questions for those who are able to stay on the line. So again, we're going to pull up the poll, and if you can't see the poll because it's a pop-up, you can type the letter of your answer into the chat. Just please remember to send it to everyone. And Jake, as soon as you've got enough answers, let me know and we'll share what the correct answer is. Okay, we've got one in chat. How many have answered the poll, Jake?
We have a good 38% that answered.
All right, great. So let's pull up those results. All right, great. So very different from our pre-question, which is wonderful. And most of you chose A and C, which is the correct answer. So variation does lead to variation in outcomes, and standardization is one tool that can help reduce variation. But as I showed in that antibiotic graph, even when performance is 90% or better, there can still be variation that can impact on outcomes. So B is not correct. So well done, everyone. So that concludes today's session, but we have time for questions for those of you who may have any and others who need to get back to getting ready for your afternoon appointments. We totally understand. And I'll turn it back over to Jake in case anybody has any questions as we wrap up.
All right. Well, like Fran said, thank you everyone for attending. We'll leave this section open for Q&A.
You can type a question into the chat if you don't have audio, or you can ask it over the phone.
Not all at once, everyone.
Yeah, it looks like most people are starting to drop off. I'm sure they've got busy schedules this afternoon. So if we don't get one in the next 30 seconds or so, we may just want to close out the session. And we're always available via email.
Well, I would like to thank everyone for attending today. Considering that we're not having any questions, we're going to close out the session a little early today and give everybody a little bit more time. Thank you for attending. I will be following up with everyone with an email before the close of business today with the post-evaluation link. Please enjoy the rest of your day, and we'll see you on the next call.